Hello everybody, I am Dr. Deeksha Pandey and you are watching Urogynecology for Beginners. And I have with me today Dr. Ala Monica, who is about to finish her fellowship in Urogynecology with us.
Yes.
So Monica, what are we going to do today? What are we discussing?
Case discussion today.
So discussion we are doing today, though we had, I think in 1 year, 1.5 years, we had such interesting cases. But always something else comes first and we are not able to do many case discussions. But this case was more practical.
Yes.
And maybe it is management was easy. So we thought today we should do one case discussion. So we are doing it after a long time today. I think. Okay, Monica, so without further delay, we'll just start with the history of the patient.
Ma'am, patient is actually referred to us, ma'am. She is a 49-year-old peritoneal to normal deliveries, referred to us with CT finding of urethrovaginal fistula, ma'am.
Okay. So patient was referred as urethrovaginal fistula to do the needful.
Yes, ma'am. To do the needful.
So tell me more about her history.
Yes, ma'am. She has a very long history and poor lady. She was operated many times, ma'am.
So I think 10 or 11 times she has gone inside you.
Yes, ma'am. Yes. So her history goes like this, ma'am. She's 49-year-old and at 35 years she had undergone hysterectomy for AUBL, ma'am. So at 2010 she had undergone. 10 years she was asymptomatic. Post hysterectomy also she actually had one complaint, ma'am. Post hysterectomy, after 1.5 months of her hysterectomy, she had continuous urine leakage. But for that, she was not evaluated. Neither her reports were available with us. She had continuous urine leak, urine dribbling. She couldn't pass urine in the bathroom. They were not evaluated for any fistula, but conservatively managed for 3 months. Post 3 months, it was.
It is a normal thing. Small fistula, if conservatively managed, will heal.
Yes. Okay. And it healed. Maybe she was telling she got symptomatically better after 3 months with conservative management only. So 5 years she was asymptomatic, ma'am, and 5 years later she had acute left clawing pain, for which she had gone to a private hospital where they have done open urethrolythostomy. During that time, actually, they tried cystoscopically, but it was a failure, and they have gone to an open approach. There they have written the findings as ureteric volume was less.
Ureteric or urinary bladder?
Urinary bladder. Ureter was not negotiable for them. Ureter was not negotiable, so they done the surgery, and post that surgery only she had this complaint.
For last 5 years.
5 years.
What were her complaints?
She had frequency, she had urgency, she had burning micturition, but there was no urge urinary incontinence or stress urinary incontinence. This frequency, urgency, and burning micturition persisted off and on for 5 years, ma'am, and she had taken all the tablets in textbook for this complaints, and for 1.5 years she has been showing local hospitals for these complaints and managed conservatively.
But Monica, if I remember, many times she has gone to OT where some cystoscopy has been done.
Yes.
And same thing again.
Yes, after 1.5 years. This study comes after 1.5 years. 1.5 years she was doing this, and after 1.5 years, around 2023, she again had, for this frequency and burning micturition only, she had gone to a hospital where they have seen a debris or a small little calculi in the left ureter again. So they have gone and done one cystoscopic erythrolythostomy, ma'am, again. They tried to do, actually on post-op day she had bleeding hematoma formation there. So she was rushed again. So she went into septic shock, kept in ICU for bronchopneumonia, urosepsis. She was managed there for 15 days, ma'am, and off and on she was put on DJ stenting and removed, and again kept with a long duration Duracell DJ stenting for 9 months. So overall her procedures were around 9 to 10 months.
Okay. So if with this kind of history, surgical history patient gives, and her diagnosis somebody has made urethral fistula, that is okay, because we always say that for fistula to happen there should be a preceding event. So this patient definitely had some preceding event, so there is no harm in thinking that. But now, Monica, I want to, when this diagnosis is already established, what are the problems according to your understanding patient should present with in a case of urethral fistula?
Yes, ma'am. our main concern regarding this diagnosis was, ma'am, she never had urethral fistula symptoms.
So I'm asking you the same thing. What
Yes,
are the
ma'am.
symptoms?
Symptoms, ma'am, she never had post-micturition dribbling, spraying or splitting of urine.
So you have to understand that it is unlike bladder fistula. Bladder is a storage organ. Bladder fistulas and urethric fistulas are always they always have urine in them. So they come with continuous leak. Okay. While urethral fistula is different because it is just a conduit. So patient will not come leaking all the time. She will have problems only related during voiding or during micturition. Okay. So any complaint that time double voiding can be there. Okay, all those things can be there, but it can be only related to a multiple infection. Urethritis can be there, cystitis can be there. So all these symptoms can be there, but she did not give history of any of the symptoms which were suggestive of urethral fistula. Rather than she gave history of urgency frequency. These are mostly bladder storage problems, not the voiding or conduit problems. Okay. So let's move forward from the history. Was she a diabetic?
No,
she was luckily she was not a diabetic. So now moving on to her examination. So I will skip the part of general examination, abdominal examination, other than surgical incisions if you got something, nothing. Then coming to local examination, pelvic. Tell me what are the findings you got on speculum examination, and if you tried to do any other test to confirm or refute the diagnosis with which patient has come to us.
Yes. Actually, in OPD we have seen, ma'am. In OPD there were no continuous leak or no any other symptoms which could give a suspicion of urethral fistula, because urethral fistulas could be very visible, ma'am. If they are big, they are visible actually. So nothing was there, ma'am. Mucosa was healthy. It was not,
because it occupies the entire 3 centimeters of the vaginal wall. So it can be, if it is there, unlike high bladder fistulas, you can most of the time see the fistula.
And actually the length and the width they have given is also big, ma'am. 5 mm they have given,
So
and
5
2 centimeter length. So
Yes.
it was not there, not at all visible. That gave us little suspicion.
And
then
little suspicion from history.
from history,
And then
little
little more suspicion from inspection.
And then we had gone ahead with the examination, ma'am. With you, we have done one examination.
So before that, Monica, one thing important. So what we did, because that is helpful, first you have to understand the history of the patient. So every time when we interview a patient in OPD, it is not always possible to understand her daily life.
Yes.
So before going into this examination, if you remember, we admitted this patient and told her to make a 24-hour bladder diary. Based on that, we next day we proceeded with the examination. So what was your interpretation from her? Can you describe a little bit how was the bladder diary?
Yes, ma'am. Her bladder diary, ma'am, every half an hour she used to void, and she had urgency episodes also, but never urged incontinence episodes. And
So leaking was urge, continuous, no leak was there.
No leak was there, and she's very well educated. We didn't have to have a suspicion also whether she's telling lies or like she's confused. She was very educated and she never had leak. But every half an hour, first actually it was 10 to 15 minutes only. But night it has little half an hour she could get sleep. That's it.
So this is so agonizing that 15 minutes to 30 minutes patient is getting up every time going to pass urine. No leaking, and how much volume was there?
50 ml.
Only 50 ml. Usually bladder capacity should be around 500 to 600 ml, and patient should pass urine every 3 to 4 hours. Okay. So her frequency was high and voided volume was very less. Okay. So with that diagnosis, and we have already started because the picture was like infection. So we have already started Norflox. And Norflox is such a beautiful medicine that single dose also works for that. And next day then we went ahead and did the examination because now our diagnosis, because of multiple factors, urethral fistula was not in our minds. Okay. So what did we wanted to check? How did we proceed further?
Yes, we proceeded further.
So what was our preliminary diagnosis for this patient?
We were thinking overactive bladder.
Overactive bladder, okay. And maybe reduced bladder capacity. Low bladder compliance because she has to pass with urgency 50 despite treating the infection. Okay. So we were thinking, so what did we do now for
Yes. For that, we have gone ahead and did one ultrasound to check her post-void residual volume, which was not much, and her pre-void volume was also not much actually. It
So
was
how much
around
was
100 ml.
100 ml pre-void and post-void
Post-void
also
was
some 8 ml or 10 ml.
10 ml, yes. When she was feeling to void, we have put one catheter now. We have measured how much of the urine was in the bladder. It was around 50 ml, which she was voiding, around 50 ml.
So we tested by direct catheter
Catheter
also.
also.
How much was the urine? We did it with the help of ultrasound
Yes,
also.
yes. It was 50 ml only, na? And then we have serially we have retrograde bladder installation was done with normal saline, na? And we have asked her to tell when she was having first sensation, when she had urge. Her first sensation was around at 20-30 cc only, na? And she had urge at 90 cc. So
So it is a kind of urodynamic study
Yes.
which you can do, all of you can do in your OPD. It is called office cystometry. Okay, so what you do, we were filling slowly her bladder with 10 ml increasing volume and then asking patient when she was having
Yes.
desire to
This
void.
is what.
So what was the findings, Monica?
Ma'am, she had first sensation at 40 ml and urge to void at 90 ml.
90 ml she could not
She
hold
could not
for that.
And we went ahead and gone with one more 10 cc, ma'am, and she started having pain. So her maximum bladder capacity we can tell is around 100 cc.
Less
only.
than 100 ml.
Less than
Then we have to see if somebody has sent a patient with trust to you saying that you manage this patient, she's having a fistula. And CT scan has shown one fistula before that. So what it is your responsibility that you should not be missing any small little bit. So what did we do for that?
Then again, ma'am, we have removed the urine in the bladder. We have filled the bladder with methylene B. Then we have asked her to cough. There was no leak.
And we were doing speculum
Speculum
examination.
examination simultaneously, and we asked her for cough. Nothing was there.
That
It
no
was
leak
clear,
was
no
there.
leak.
So bladder fistula
Ruled
ruled out.
out.
How do you rule out urethral fistula now?
Then we have pulled out the catheter, now.
So deflate the
Deflate
catheter.
the catheter, pulled out the catheter. At the external urethral meatus, we have kept the catheter, and then we have injected around 10 cc. And we were seeing any discoloration in the vagina or the speculum. Nothing came out, not even one
So we
drop
were
came
very sure that
Yes.
this is not a case of. So our final diagnosis was
overactive bladder with low bladder compliance.
compliance. Very good. And based on this diagnosis, we started managing this patient. Okay. And what do you do? The management is so simple. Can you tell me the steps of management for this patient?
First, we have asked her to avoid all kinds of bladder irritants. Ma'am. We have asked her to avoid tea, coffee.
That will not
Spicy food.
increase the compliance
Yes.
but help her
And
with the urgency.
Yes.
a little bit.
we have asked her to do that, and we have asked her for bladder training also.
Very good.
And then we have asked gave her bladder drill, how to chart it, bladder diary and all. And then we have started her medical management with mirabatrone. First, we have started at 25 mg BD. Then we have increased the dose. Titration was done to 50 mg BD. And as she was not sleeping at all in the night, ma'am, which you always tell sleep is the best medicine. So we have also added one Zolfrish.
With this, how much improvement patient told you her symptom in a 2-3 days time?
Yes, ma'am. We have maintained a score chart, ma'am. How was just a symptom, patient perspective,
Overall.
subjective score chart, ma'am. Her frequency has improved from 10 by 10 to 5 by 10. So 50% improvement.
there.
Her nocturia, actually, she used to go every half an hour. Now she's only getting up at 2 or 3 times. For her, it is a big win, ma'am, actually. Then her urgency is gone. Anyway, she never had urge incontinence or SUI. She never had burning micturition or dysuria after that. So she's symptomatically very better.
And now patient, we have sent the patient back and patient has come back after 15 days
Yes.
also, after 2 weeks for a review. And there is,
Yes.
patient is happy, satisfied,
Yes.
and there is a lot of improvement in her symptoms.
Yes.
Now, Monica, are you happy with the 50% improvement? I'm not happy. I want to make the patient better.
Yes.
So, do you have any other tools in your toolkit with which you can help the patient?
Yes, ma'am. We have one more toolkit with us for overactive bladder. We can give her intravesical Botox injection. We were just waiting for her to complete at least 4 weeks of mirabatrone therapy.
Maybe little more because the maximum effect of mirabegron comes in 12 days.
12 days.
Okay, 3 months it takes. So we'll give it a maximum try. Botox injection will also relax the bladder and will help the patient with her symptoms. So these are our plan of action, and I am very sure that without any big intervention, this patient is going to do much better.
Actually, I remember them telling again and again that we have done 10 surgeries, nobody gave medicine and it cured.
And that is such a good feeling.
Yes.
Okay. But one thing, maybe this is the last point I would like to discuss. Have you seen the CT scan for this patient?
Yes, ma'am.
Was there a fistula?
Yes, ma'am.
What is your explanation and what did you do? Because if one investigation flows and you cannot leave it,
Yes.
then what did you do after this?
Ma'am, first they have come with CT, we have done examination.
No,
Again,
that is okay. Any imaging, because you
Yes,
have to keep a proof, or at least for
Yes.
academic purpose. For radiology, it is learning for everybody.
Yes.
When one fistula tract was seen, we have to see whether it is artifact or it is really there in imaging also.
MR fistula.
So MR fistulogram we did, and there we found out that there was
No
fistula. So from where did this artifact came? Okay, you want to tell or should I tell?
I think it will be better if
Okay.
you tell.
So I'll quickly tell. So what happens when the bladder capacity is very low? And this fistulogram for urethra, when we tell the patient to void. Even if you don't tell the patient to void, because the bladder capacity is so low that while lying down on that table for CT scan, patient might feel she can't hold it, she cannot run away from there. And she is used to leaking, so she will leak there only on table on whatever 50 ml amount of volume. This urine spills out, and because of the proximity of vagina and the negative pressure of vagina inside the cavity, the fluid gets sucked inside. Okay, that's why in images what you are seeing that this fluid was occupying even the vagina. That was the radiologist's question, that how it is there. It is there because of spilling of urine out in negative suction. In women, both the orifices are just next to each other, so it is very common for urine, little bit if it is spilled, to suck in and show a signal in CT scan. So that's what has happened
also. Outside the
outside so you can see the spill. So it is one more reason how you can different your diagnosis. So I hope this patient does very well. And not only today, I really appreciate the way you took detailed history. Today, though you summarized, but that day that you took my 45 minutes to make me listen to the history, because by that time we have not reached to a diagnosis when you were presenting for the first time. I really appreciate it. I hope our viewers would have learned something from this case, the power of medical management and a correct diagnosis. And this last line I want to tell, which I tell to my students every day, that you don't treat a urodynamic trace, you treat a patient. Likewise, you don't treat a CT, MRI or ultrasound. Your aim should be to treat the patient, not to trace and not an image. I hope that is enough for today. So keep watching.
Thank you, everyone.